So, good morning, welcome all. So, today we are having a CME on high frequency ventilation. So, why this CME? Because I mean, when I was an MD student, always we used to get fancied by whenever we hear the term high frequency ventilation as if it is something magical. So, and of course, then moving ahead, when we entered DM and when we completed DM, we understood that not all the times it will be helpful. So I thought it is the good way to teach the residents if we could have a CME, because high frequency ventilation in itself is a bigger topic, and I think even 2 hours would not be sufficient, but we'll try to cover as much aspects as possible. So for the first session, we have Dr. Abhijeet Roy. So he has done his MD in pediatrics from BHU, and then he has done his DM in neonatology from SGPGI Lucknow. He has also worked in the past as assistant professor in the Department of Neonatology at SGPGI Lucknow, and presently he is working as the head consultant neonatology at Madcare Hospital, Varanasi. So over to you, sir, for the first session.
Uh, First of all, very good morning to everyone, and I'm very thankful to Sandeep for inviting me for this talk. So I'll talk about the high frequency ventilation, its historical aspect, and understanding the physiological basis and need for high frequency oscillation ventilation in units. So I'll talk a bit about introduction, then about the historical aspect of high frequency ventilation. We'll understand the physiology behind high frequency ventilation and its comparison, side by side comparison with the mechanical ventilation, uh, and take messages. I will also talk about a bit about nasal HFO. So, as we know that neonatal respiratory failure is very common and serious clinical problem in neonatal settings, and mechanical ventilation has been used as a bridge therapy for these babies. So, the basic goal is to restore the lung function with optimal gaseous exchange with minimal adverse effects. Optimal outcomes can be achieved only if the appropriate strategies are being used to address the patient specific pathophysiology. Uh, and in this the help comes from the protocols and guidelines it, based on the individualized patient care. So as we understand our understanding of conventional ventilation, there are basic modes which include intermittent mandatory ventilation, SIAV mode, then assist control mode, pressure support ventilation, and volume control ventilation. So this is what we know. But what happens with the ventilation is that whenever we have a baby, we put the baby on ventilator, we start with minimum settings, then the baby worsens, then we have to keep on increasing the ventilator settings. And this results in majority of the time ventilator-induced lung injury, which can cause damage to lung via pressure, which is barotrauma, or with the volumes, which is volutrauma, then continuous opening and closing of the alveoli, which can lead to trauma. Then there can be infections, which with literally pneumonia and biotrauma. So why HFO? Because it helps in optimizing the lung volume. Uh, we open up the lung and keep it open via high frequency ventilation. So a bit about history. In 1915, Henderson et al. They saw a panting dog. So they, they, they seen that the dog is panting effortlessly and without getting hypoxic or hypercapnic or hypocapnic, and they still ventilate very well. So the tidal volume less than dead space can also be effective. So this was a landmark experiment which was published in the Journal of Physiology in 1915. So what they conducted is so up, so they took a glass cylinder about roughly say 1 meter long. It was a hollow cylinder, and a puff of smoke was given at a fast pace. So the tip of the smoke came out in conical fashion as it came out in the conical fashion as it can be visualized without the entire chamber filling with the smoke. So then subsequently, uh, if the pressure was applied at the opposite end, suppose if the pressure was applied at the opposite end or the flow was slowed, then the smoke would fill the entire chamber. So this was what seen by the Henderson and all. And what does it imply? It implies that through the convection, we can produce a flow streaming which can help in gaseous exchange. And once this flow is stopped, then the diffusion, once the flow is stopped, which happens during the expiration, so the diffusion of the molecules can occur, and it is one of the mechanisms in high frequency ventilation. So more about historical perspective. In 1915, the experiments were carried out by Henderson et al. Then in 1950 to 1917, Dr. Emerson, Dr. Bird, and Dr. Bunnell introduced high frequency ventilations. Then there were successful animal studies in 1970, and FDA approved first trials on HFO in 1980. In neonates, the HFO came into use in 1990, and subsequently in the adults in 2000, and then came the concept of nasal HFO in 2013. So what is the working principle for high frequency ventilation? Mostly piston oscillators are used. So this is the oscillator, this is the piston, this is the oscillator. So they generate a set amount of pressure, and through this, then the fresh gas flows in via the bias gas flow, and during expiration, and the extra gases, they pass through low pass filter. So there are different types of high frequency ventilation. These includes high frequency oscillation ventilation, high frequency jet ventilation, and high frequency flow interrupters. So in high frequency oscillation ventilation, as we know, the pulse is generated using a piston or a diaphragm. Then I to E ratio is 1:1 or 1:2. That is inspiratory to expiratory ratio, and frequency is usually around 8 to 15 hertz. So 1 hertz is around 60 cycles per second. So multiplied by 60, we can get the frequency. Then yes, we can impose the sigh breath. What is sigh breath? It is additional breath besides the high frequency oscillation ventilation. So in some ventilators, there is we can superimpose a sigh breath, and it is usually helpful in babies with having ARDS, acute respiratory distress syndrome. In high frequency jet ventilation, the pulses are delivered by the pinch valve. So a pinch valve is there, which delivers pulses over the conventional breaths. Then I to E ratio in this scenario is 1:4 or to 1:8, and the frequency is lower, 5 to 10 hertz. And also the pressures in high frequency jet ventilation is lower than the high frequency oscillatory ventilation. And in this also, we can superimpose the sigh breaths. Then in high frequency flow interrupters, solenoid valve is used to generate the pulse waves. Then I to E ratio is 1:3, and frequency is between 8 to 12 hertz. So what are the basic principles for high frequency oscillation ventilation? So there is a CPAP system with a distant displacement of the gases, as we already understand this. Then the ventilation occurs at small tidal volumes, that is 1 to 3 ml per kg. So at times in conventional ventilation, the ventilation occurs around 5 to 8 ml per kg, and of which roughly around 1.5 ml per kg is the dead space. Dead space accounts for the both anatomical dead space as well as the alveolar dead space. But in high frequency oscillation ventilation, what we are doing is we are ventilating the baby at still very small tidal volumes, which can at times be lower than the dead space. So how this is achieved? This is achieved using a small pressure variations around the map. So the piston vibrates and it generates gases at a set pressure, and then there are small pressure variations around this map. So and this pressure variations are delivered at a very high rates, that is 180 to 900 breaths per minute. And also there is decoupling of oxygenation in ventilation. What does it mean? It means that the parameters controlling the oxygenation is different from the parameters controlling the ventilation. And in high frequency ventilation, in high frequency oscillation ventilation, how is it different from jet ventilation? It also has active expiration. In conventional ventilation, there is passive expiration. Also in jet ventilation, there is passive expiration. But in high frequency ventilation, high frequency oscillation ventilation, we have active expiration. So these are the various ventilators providing high frequency ventilation. So this we can see what happens in conventional ventilation. This is the alveoli. So it opens and then it closes. So this is what happens in conventional ventilation. There is partial closure of the alveoli in conventional ventilation, but what happens in high frequency ventilation? It remains open. This is this we will see. So this this is the schematic representation. So this is the trachea, and these are the trachea, or it can be like alveolar duct, uh, airway, and then these are the alveoli. So what happens in the conventional ventilation? It will be demonstrated. So how you can see how the alveoli open during the conventional ventilation. So this is how the alveoli open and close during conventional ventilation. And now we will see what happens during the high frequency ventilation. So the alveoli keep distended during high frequency oscillation ventilation. So so as we know that during the conventional ventilation, there is chances of over distension as well as chances of atelectasis. So this will lead to barotrauma and this will lead to atelectotrauma. But in high frequency ventilation, there are smaller tidal volumes. So volutrauma is also less, and also it operates between the safe window. Then another aspect of high frequency ventilation is that during the conventional ventilation, what happens is that as we go down the airway, there is no pressure attenuation. So suppose this is the PEEP, this is the PEEP, and that the map would lie somewhere in between. So there won't be any pressure attenuation, and the map will remain constant everywhere. So the peak pressures reaching actually the tip of the alveoli is very high. But in what happens in high frequency oscillation ventilation is that there is, as the resistance increases down the airways, the map will be delivered will be same, but there will be pressure attenuation of the amplitudes. So there will be sorry there will be attenuation of the amplitude, and the peak pressures delivered will be less during high frequency ventilation. So pressure injury would be less. So what is the advantage? Here we can see that in the conventional ventilation, the dynamic behavior of the alveoli could be seen, and there is the architecture is distorted. But what happens in high frequency ventilation? There is continuous descending, and the architecture of the alveoli is preserved. So this helps in better surfactant pooling, whether we give it exogenous or endogenous surfactant is there, and also less injury. So now, how about the gas exchanges occurs in various modes of ventilation? So in conventional ventilation, there is mostly the bulk flow. So the the air is pumped into the trachea and then into the smaller airways. So the gaseous exchange occur here, and this is the bulk flow or convection flow. And what happens in the distal airways at the level of alveoli, the diffusion occurs. But for the gas exchange to occur in a conventional ventilation, we have to also keep into the account for dead space, which is alveolar dead space as well as the uh, anatomical dead space, where the gas exchange does not occur. Alveolar dead space, how does it arise? Is the part of the lung or the alveoli which is non-perfused, will result in non-exchange of the gases. And how the exchange occurs in a jet ventilation. So here, here in this video, you can see, just play again. Just see the orange line. So that was the inspiratory air which was being jetted into the trachea and then subsequently into the smaller airways. And this is the smoky bluish line. It shows the expiration of carbon dioxide. So how it occurs? As we know that there is the jet of air flows in the conical fashion. So this is how it flows, and then their carbon dioxide swirls around it and is exchanged. And this is how the exchange occurs in a jet ventilation. I hope you are able to understand. So how the gases exchange occurs in high frequency oscillatory ventilation. So there are various mechanisms. This include the bulk convection. Then there is one of the prominent methods for gases exchange is Taylor dispersion, and then a Pendeloft. Pendeloft mechanism accounts for almost around 50% of the gas exchange. Then there can be collateral ventilation, asymmetric velocity profiles, or eddy currents. Then there can be cardiogenic exchange in molecular diffusion. So we'll be understanding one by one all of these. So what happens in the direct alveolar ventilation, that is convection or bulk flow? So the proximal alveoli, it gets aerated because of the bulk flow of the gas. But its role in a high frequency ventilation is limited because as we know that there is pressure attenuation at the distal end, so less and less gases are exchanged by this mechanism. And also the tidal volumes are small. In what happens in augmented Taylor dispersion, as we know from the smoke study that the gas passes in a conical fashion. So there it will be, so this is the conical end and there will be linear laminar flow here. So as as there is as the gas is flowing, it will produce it will the oscillations will cause better dispersion uh, at the part in line with the airway. So this will help in the gaseous exchange and effective gaseous exchange. So this is because of the shearing and spreading of the gas uh, at the uh, co- at the junction of the airway and the gas flow. This will help in efficient removal of the carbon dioxide and improves the oxygenation delivery even at low tidal volumes. So what happens in the pendulum mechanism? So what happens is that there are various alveoli which are at different time constant. So some alveoli may be small and they may have increased airway resistance, uh, decreased compliance, and these will be having higher time constant. And some of will be having lower time constants. So those with lower time constants will be filled earlier. So they will expand. So what happens once they are filled, they will pass the gas to the nearby alveoli also. So during expiration, what will happen? This alveoli, because it has a lower time constant, will empty earlier, and this will still be having gas. So the gas exchange will occur then in the second time. It will occur from this alveoli to this alveoli. So it is clinically useful in ventilating heterogeneous lungs such as RDS, where some of the alveoli open and close at faster rates than others. So it is one of the prominent mechanisms for the gaseous exchange. Uh, Hemodynamic effects in cardiogenic mixing. What happens is that if we provide too much of MAP, then it will, if we provide optimal MAP, then it helps in recruitment of the lung, and also the pulmonary vascular resistance is lowest at the optimal uh, MAP. But if we increase the MAP, it will decrease the pulmonary vascular resistance, and we may end up in compromising the baby hemodynamically. But if the baby is optimally recruited, hemodynamic effects will be maximum and the ventilation perfusion ratio will be the best. So this is particularly useful in PPHN. So what happens in cardiogenic mixing? So as we know that the baby is not actively breathing. Baby is not breathing on its own, and there are small fluctuations of the tidal volume. So the lung adjacent to the heart also helps in also the gaseous exchange occurs because of the beating of the heart, and it contributes minimally, but still it does helps in gaseous exchange. So for molecular diffusion, as we know that this occurs at the level of the interface between the alveoli and the air. And what happens in asymmetric velocity profiles that so I'll talk in this. So just to revise, I'll explain asymmetric velocity profiles a bit later. Just to explain a bit, there is direct ventilation of the closed alveoli, and this occurs through the bulk convection method. Then there is pendulum mechanism in which two alveoli are, because of having different time constants, they get alveolated, they get ventilated. Then there is a mechanism for diffusion at the tip. Then there is collateral ventilation in which the alveoli are connected. Then this occurs in distal airways where Taylor dispersion is the prominent feature, where we can see the conical shaped inspiratory gas. And because of the shear stress, it causes mixing of with the surrounding air and better gas exchange. What happens in asymmetric velocity profiles, as we know that in HFO ventilation, inspiration is active. So there is a conical gas in the airway with and expiration is passive. Sorry, expiration is also active. So it will uh, it will suck the air actively. So this results in plateau phase expiratory velocity profile. So velocity because expiration is active. So as this together when combined helps in better gaseous exchange, better mixing, and also there is additional effects of Brownian movement, that is random movements. So this is the waveform of a typical high frequency oscillation ventilation. It is a sine waveform, classical. It is a sine pattern waveform. So this sorry, this contributes one cycle just to understand. Then there is a map and around which this is the amplitude around which the pressures are delivered around the map. Then frequency, as we know, the number of cycles in 1 second, that is frequency. And area under the curve, that is this area, it is a tidal volume. So as we know that when a ventilation is a product of frequency into tidal volume square in high frequency oscillation ventilation. In conventional ventilation, what happens? It is the product of frequency into tidal volume. But in high frequency ventilation, it is a product of frequency into square of tidal volume. So suppose if we are giving a frequency of 15 hertz, then we can see the area under the curve is small. है ना? So tidal volume will be less. So in high frequency ventilation, what happens if we increase the frequency, then a tidal volume delivered will be smaller and the square will be smaller. So it will result in carbon dioxide retention in the baby. But if we decrease the frequency, then area under the curve will increase, tidal volumes will increase, and therefore uh, there will be better ventilation and better carbon dioxide removal. So classically, as we understand conventional ventilation, there will be a removal of carbon dioxide if we increase the frequency or rate. But in high frequency ventilation, if we increase the frequency, there will be decreased carbon dioxide elimination. And if we decrease the frequency, there will be increased carbon dioxide elimination. So as we know that there is oxygenation and deoxygenation, oxygenation and ventilation decoupling. So what does it mean? That the parameters to control oxygenation is largely independent from the parameters that control ventilation. So that we can micromanage the oxygenation and ventilation part. Oxygenation is controlled by mean MAP, that is mean airway pressure, and FiO2, and ventilation, that is carbon dioxide elimination. It is controlled by the amplitude and frequency. So how does a map helps? It helps in recruiting the alveoli, helps in providing a continuous descending pressure, and hence prevents electrical trauma. Also one of the side effects of increased map is that if you increase the map too much, then it can lead to hemodynamic compromise because the vessels, large vessels, will get compressed, and that will increase the pulmonary vascular resistance. So about frequency, as I have already told, the frequency set for the depends on the weight of the baby. Lower the weight of the baby, we have to keep the higher frequency because it helps in it, because it is at that frequency it has been observed that the gas exchange occurs the best, carbon dioxide removal occurs the best. And if the baby is of higher weight, then we have to keep the frequency on lower side. So for term babies, it is usually around 8 to 12, optimally around 8 to 10. And for preterm babies, it is between 10 to 15, optimally around 12. So amplitude, it is the force and distance with which the piston moves from the baseline, and it is clinically demonstrated by the wiggle. So then one of the parameters that we keep in the ventilation is I/E ratio. So normally there's a lot of debate about whether we should keep I/E ratio 1:1 or 1:2. So in conventional ventilation, we usually keep around 1:2. So that is being extrapolated to the high frequency ventilation also. What it helps is that the delivered intraalveolar pressure is significantly lower than the set map. So it helps in protecting from the barotrauma at the expense of optimum alveolar recruitment. So if it is not, if it can lead to atelectasis. But in my personal opinion, there is not much of difference in terms of gas trapping or in optimal alveolar recruitment. So theoretically, one may say that if we keep the I ratio 1:1, then it can lead to barotrauma. Then there is another terminology, diffusion coefficient of carbon dioxide. So what is DCO2? It is a mathematical model which predicts the chances of normal PCO2. It is a product of tidal volume square into frequency. So for every baby, DCO2 is different. It depends on the weight of the baby. It sees an oscillatory frequency. Uh, if the baby is spontaneously breathing, then the DCO2 requirements are lower. And ideally, it is 40 to 60 ml per square per kg square per second if the infant is spontaneously breathing, but it has to kept at maintained at a higher rate, that is 60 to 80 ml square per kg square per second if this baby is having minimal spontaneous respiration. So this is a rough guideline for depending on the weight of what DCO2 we have to keep. If the baby is spontaneously breathing. So if the baby is of 1 kg, we have to keep between around 40. And if it is of 2 kg, then we have to keep around 160. So there is a newer concept of high frequency oscillation ventilation with volume guarantee. So nowadays, in many of the ventilators, if we use a flow sensor, then we can provide volume guarantee. Ideally, roughly you can remember 2 ml per kg, this number. So predefined tidal volume we can give, and it helps in maintaining the stable arterial PaCO2 and hence a stable cerebral blood flow. Then what are the indications? Usually, if there is a failure of conventional ventilation, indications will be talked in detail in the next talk. So if there is as a rescue therapy, then also we have to understand that we have to provide the rescue early, not late. As Sandeep had already told that it is HFO is some magical. It does act as a magical therapy, but then we have to decide early. So it can also be used in PPHN, in respiratory distress syndrome, while administration of inhaled nitric oxide, and in some scenarios where there are surgical abdomen or NEC or congenital diaphragmatic hernia, where the limitation in the abdominal movement or chest movement, uh, if we want a limited movement of the abdomen or chest, and also in cases with pulmonary hypoplasia. In air leaks, it is useful. How does it help? Because as we know that the pressure fluctuations are minimal. We are operating at a set map and around which a small amplitude is given. So the pressure fluctuations is minimal. What happens in conventional ventilation is that there is a PIP and PEEP. So the pressure difference is large. So as we know that gas flows from higher pressure to lower pressure. So during inspiration, the gas will flow from more into the air leak part. But in high frequency ventilation, that gradient is less. So it is useful in air leaks. So for rescue therapy, how do we define the failure of conventional ventilation? Usually, if we are reaching PIP of around 25 to 30 centimeters of water with respiratory acidosis and PCO2 more than 60 millimeters of mercury, if there is oxygenation failure, or if oxygenation index is more than 15. Then a bit about nasal high frequency oscillation ventilation. It is a relatively newer non-invasive modality. It has been seen effective and superior to an IPPV in terms of carbon dioxide elimination. So it applies an oscillatory pressure waveform to airways using a nasal interface. So which type of interface? Mostly it is preferable to use nasal pumps compared to mask. Uh, Advantages, it helps in high carbon dioxide removal, less volutrauma, less barotrauma, and less invasive interface. It helps in maintaining the FRC and improving the oxygenation. So it can be at times useful in avoiding the need for invasive ventilation and therefore its complications. So the basic principle is that there is a bias flow generating a continuous descending positive pressure. It may be provided with ventilators having oscillating piston and have active expiratory phase. Oscillations are superimposed on spontaneous tidal breathing. So the babies are normally breathing spontaneously and there is no need for synchronization. Then it will have, as in HFO, invasive HFO, it will have a constant frequency and active expiratory phase. So this was one of the studies where nasal HFO was studied. So what they found in RDS babies is that a nasal HFO significantly reduced the duration of non-invasive ventilation and decreased need for intubation. So my take-home messages: high frequency oscillation ventilations, these use very small tidal volumes, often less than the dead space, which are delivered at extremely high rates and therefore minimizing the lung injury. So gases exchange in HFOV is achieved through various specialized mechanisms such as Taylor dispersion, pendulum, then convection pulse flow, and many other mechanisms like collateral and molecular, then diffusion, then cardiogenic mixing and all. Then high frequency oscillation ventilation, we need to understand that it maintains a constant in airway pressure, therefore promoting alveolar recruitment, which is also known as the open lung strategy, preventing atelectative trauma and also barotrauma, volume trauma, and providing for better oxygenation and gas exchange. There is oxygenation and ventilation decoupling. Then it is particularly useful for the babies as they have compliant chest wall, small lung volumes, and they're also vulnerable to volume trauma in conventional ventilator. Thank you. So I hope you have understood a bit. It's all physiology, and if there are any questions, I'll be happy to answer.
Thank you, sir. It was very informative talk. So since there are many MD residents who are attending the session, I'll just summarize what sir has told. So basically how high frequency ventilation is different from a conventional ventilation. So first of all, in conventional ventilation, we use physiological rates, that is somewhere around 40 to 60 breaths per minute for a baby. Okay, but when it comes to high frequency ventilation, the rates are very high. As the name suggests, it is high frequency. So you are using rates which are say somewhere around 180 to 900. Okay, that could be the range. So any breath which is more than 180 becomes a high frequency. So that is one of the difference. Second is that the tidal volumes which we are using are very small. Okay. So in conventional ventilation, we are using tidal volumes around 4 to 6 ml per kg. Okay. Problem with using such tidal volumes for a baby with normal lungs, they may be good. Okay. But sometimes there are situations we see in our day-to-day practice where, the pressure requirement, the volume requirement is high. And when you go higher on the volume, the problem is you cause more damage to the lungs in the form of volume trauma. Okay. Something what we call the ventilator induced lung injury. So to prevent that, if you speak on paper, the high frequency ventilation uses a very small tidal volume. Okay, because we are using very fast rates, you can achieve the oxygenation and gas exchange with a very small tidal volume. So somewhere around 1 to 3 ml per kg. So the volume trauma chances would be minimum. The rates are on the higher side and you have a constant descending pressure. Now, what happens is that when you're using conventional ventilation, you are using two pressures. Okay, one is the peak inspiratory pressure, one is the end expiratory pressure. But when you're using a high frequency ventilation, there is a constant descending pressure. So it is in the form of a CPAP. Okay, so all these are the advantages. There are various mechanisms of gas exchange, okay, which sir has highlighted, the Taylor dispersion, the Pendelov effect, and bulk convection. Okay, so all these mechanisms, we do not know how much they contribute at each level, but these are all the proposed mechanisms which help in gas exchange during high frequency ventilation. Okay, if there are no questions, I think we'll move on to the next talk. Once again, thank you so much, sir, for sparing the time from your schedule for this talk.
Thank you,
And
Sandeep. Actually, a bit I got occupied because we had a triple delivery and there is another twin delivery lined up.
okay.
So we are having a hectic day today.
No, thank you so much, sir.
ठीक है,
Thank you so much.
ठीक है, thank you, yeah. Thank you, everyone.